I can't do it by myself as the healthcare professional, and the patient can't do it by themselves either. We need to work together. And I think that that's a nice thing to talk about, but there are ways that we can actually operationalize that really do make a big difference, right? And so how do you do your part, I do my part, we work together, and we both have really great outcomes. I think a lot of times as oral health professionals, we get really dialed on like one thing that we see that's a huge problem or huge leverage opportunity, if you will. And that's good, right? Because we want to identify high leverage changes that patients can make and help them, actually make those changes. But if that's not possible, or if that's too difficult, well, then let's make some small changes that are wins. We don't want to project our values onto other people when making those treatment decisions. And so helping people understand the risks and the benefits and the alternatives in a way that takes into account their values and preferences, I think is just so crucial.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
All right, welcome back everyone to another episode of A Tale of Two Hygienists, episode number 319. I am your host, Andrew Johnston, and thank you so much for making us a part of your week. Everyone, we have a bittersweet show today. It is Michelle's last interview, and probably pretty likely the last time you'll hear her voice on this show. We did, however, try and brighten your day by bringing back a fan favorite, Dr. Matt Allen, and so you'll hear from him and his amazing insight that he always brings to us in just a little bit. Next week, we have another good episode with Dr. Mona Patel. She was kind enough to sit with us at Voices of Dentistry back in January and record with us. She's the type of doctor that I think we all want to be working for. I'm very excited for you guys to hear that one. Special shout out to Allison Zora from Dead Spy Serona for connecting us with Dr. Patel. And I have to say, I truly appreciate all of you, and I'm very thankful that the messages that you spend time creating these messages and hitting the send button. It really means a lot to me, and I think to all of us here at A Tale of Two Hygienists. It's incredible. I can't believe you all still do that. So I want to read one to you that we got. It wasn't an iTunes review or an Apple Podcast review, but it was still a good one. And this one is from Kimberly, and she says, "I'm a 36-year practicing dental hygienist, but my main job is a dental sales rep. I am in the car a lot. I listen to your podcast every chance I get, and I'm a big fan. As an older hygienist, I try to continue to learn and keep up to date with the latest information for my profession. I never want to become a hygienist stuck in the hygiene ways of their graduating year." I won't say what year out of respect, but she said LOL. "Thank you all for continuing to keep me up to date and the great podcast." Kimberly, if you're listening, thank you so much for that. It was, like I said, really kind. And I really want to find a way to get you on the show to talk about some of the things. I think a lot of us actually want to know what being a dental sales rep looks like for a hygienist, and maybe other different avenues that you found to stay current with the profession. I did send a message back to you, so hopefully you'll get it, and hopefully we can connect soon, even if we have to do it via Zoom or virtually. I would really like to sit down and record something with you. I think that'd be great for our audience, so thank you for that. In other news, I will be podcasting, I guess next week, actually. Wow, already. That came really fast. So I will be recording next week in Chicago at the Midwinter meeting. So if you are going, please shoot me a message so we can meet up. I know that I'll be recording Friday morning for sure. I know I have a couple of other meetings that morning as well, but I'll be there for a few days. So anytime that you're going to be there, just let me know. There's lots of events that always happen at Chicago Midwinter. I even took an extra day off of work to tour the city with my best friend, Daniel. So if you have been with us from the very, very, very beginning of this podcast, so Daniel was my non-dental friend from episode 11. He's been my best friend for many years. I mean, that's over 300 interviews ago. And so it blows my brain. So it'll be really fun. I'm excited to spend some time with him and do non-dental, just being in the city and enjoying Chicago. It's a great city. But if you are smart enough to avoid the cold in Chicago and you still want to see us, we are also going to be doing live interviews from the Hinman meeting in Atlanta, which runs from March 17th to the 19th. I'm very thankful to be part of the group of podcasts that they invited. It's a great concept. If you missed me say it before, they have dedicated a booth just for dental podcasts. So it is booth number 757. And our time slot is Thursday, March 17th from 9:30 a.m. to 1 p.m. And don't forget, just after us, we have our friends Teresa Duncan and Kevin Henry that will be doing their show from the same booth. So if you're at that meeting, be sure to swing by and say hello. If you want to record live with me, I think I have one more, maybe two more slots if we end up doing shorter episodes out of the 4. So please send me an email, andrew@atailof2hygienist.com, and I will get you slotted in for that time. Please be sure that you know that you'll be there Thursday morning. There are also some great speakers lined up at Hinman. So if you want to see who's going to be there and maybe even get registered, head over to hinman.org. They're going way out of their way to support dental podcasts. It's very unique what they're doing. So if you can make it, please show your thanks by attending that conference for whatever CE needs you have for either this year, or if you're a every 2-year, every 3-year renewal cycle, make sure you head over to this conference as well. I'm sure the weather has got to be better than the one in Chicago. So this week in social media. So last week I said, hey, we're going to start a new segment, and it's called This Week in Social Media. And I asked for feedback, which is always a double-edged sword, right? So I asked for feedback about the new segment, and the reviews were basically mixed. The majority thought that the message was good, but one did say that they didn't care about social media. So I think this is what I'll do. I'll tell you what, because it was kind of a small sample size, I'm going to give it one more week to hear feedback on that segment from that episode. If I get more positive feedback that everyone wants it to stay, then I will be sourcing every week for new content to put on that, because I think that is a time, I really do feel like it's a time that we can highlight the other professionals that are putting stuff out there in this world that's positive and awesome, and also things that just make us think. So please continue to send your feedback on that. I will let you know, I guess, in next week's episode of what the results were. Thank you, everyone, for being here, and please enjoy this episode with Dr. Matt Allen and Michelle Strange.
Well, I'm excited for this conversation for a few reasons in this interview. One, I love having our return guest, Dr. Matt Allen, is with us. And the conversation we had last time was so fabulous. So I'm really excited what will come from this one. But also, more specifically, I do not work with children and parents. So I think I'm going to learn a ton from this conversation. And more specifically, we're going to talk about how we can have conversations with parents or caregivers when we're talking about the child in the chair's disease, our need for better maintenance, the whole gamut, right, around children's oral health. So welcome to the podcast again.
Thank you for having me back. I'm super excited to be here, and it's always a pleasure to be with you, Michelle, and to get to chat about some of these really important topics. So thanks for having me, and especially during a month like this, during when we're thinking about children's oral health so much. Really excited to dive into this topic.
Perfect. So just in case somebody that they didn't listen to our initial podcast where you were on talking about motivational interviewing, if not, y'all, I almost want you to pause and go listen to that, because I think it would set up a really beautiful foundation for this conversation that we're going to have. But if they have missed that, tell us who you are, what you do, and all of those details.
Yeah, for sure. Happy to share. So Matt Allen is my full name, live in the mountains of Colorado. I'm one of 2 dentists in the world who's a member of MINT, which is the Motivational Interviewing Network of Trainers. My current work is I'm the CEO and co-founder of a company called Different Kind, and we are a patient-centric platform that helps dental professionals measure and improve patient experience. So taking some of all of the things that I have learned over my time as a consultant and as the coach for dental professionals, bringing that to a more tech-enabled solution to help dental practices really understand and hear from patients, and then actually make improvements based upon that patient feedback. So that is a little bit about me. We could chat a lot more about that, but probably just go into the topic, and we can get
well,
there.
I think it would be probably really great to talk about what a patient-centered approach is, because that's kind of what would you say that's how we're going to have this conversation? It's patient-centered, but now we're throwing in this other arm
with the parent.
Yes.
Totally. Yeah. I mean, I think, one of the things that we talk about, I talk a lot about, is the idea of patient-centered versus person-centered, and what does that mean, and how do we conceive about those things differently? And I say patient-centered when we talk about different kind only from the perspective of, I think that patient voice is often forgotten in the healthcare conversation. And patients actually really have this and we'll talk about parent desire for this as well today, but patients have this really strong desire to generally be healthy and do good things and all of that stuff. And that voice is really powerful and can really lend itself to a lot of change. But I think so often in healthcare, we get focused on what do we need to do as providers to change, and what do we need to do as systems to change, and what do we need to do as payers to change. Those conversations are obviously all very important. We just want to make sure that we elevate that patient voice for people so that they can really listen to that, be responsive to that, especially in an increasingly consumer-centric healthcare environment. That being said, when I think about the difference between just like patient-centered and person-centered, if we're just talking about healthcare in general, I tend to think that patient-centered is kind of more the biomedical part of what the patient's history is, right? So I might be very patient-centered when I'm focusing on their periodontal disease and be thinking about some very specific things about them and be very personalized in that. And that's not bad at all. But I think person-centered kind of encompasses a little bit more about the patient, right? Their motivations, their desires, their values, their preferences, all the things that makes that person tick that then potentially impact their periodontal disease as well. So why haven't they been back for their 3-month recall and it's been a year and 3 months, or it's been 5 years and 3 months, right? It's not maybe because they didn't want to come, but they probably have some things going on in their life that's making it difficult for them, or they have some other factors, right? And so when I think about if I'm just being strictly patient-centered in that situation, I might miss all of those other really important pieces that are obviously impacting that patient's overall health. So that's kind of how I tend to think about the difference between the two terms. So how does that feel to you?
No, that sounds very spot on. I'm curious if there are some foundational things that we have to keep in mind with the person or patient-centered focused approach that would be kind of mirrored or mimicked when we're talking to a parent.
Totally. I think first and foremost, when we're talking with any person about their healthcare, right, we are here as a helping professional. And I think that lends itself to some concepts like partnership, right? Like I can't do it by myself as the healthcare professional, and the patient can't do it by themselves either. We need to work together. And I think that that's a nice thing to talk about, but there are ways that we can actually operationalize that really do make a big difference, right? And so how do you do your part? I do my part. We work together and we both have really great outcomes. I think that sometimes we think about that, and that's especially true of a parent, right? Because they can't do it by themselves either. They need the support of their child. So it now becomes a 3-way partnership between us and the parent and the child to work together to achieve those same outcomes. And then I also think about this is like a very philosophical concept. If we wanted to go into this and do a whole episode on, the ethics of autonomy support and like, what does that mean? And, what is the like history of paternalism in healthcare and all of that stuff, right? Like there's lots we could dive into here, but all that to say is that I think respecting patient autonomy is really important, and respecting parent autonomy. And, I think in that, we want to assume best intentions for the most part, right? There are obviously times when that, is not the case, right? And we have to become a mandatory reporter or something like that, right? Like there's obviously times when we can't assume best intention. But I think in general, I've yet to meet a lot of parents working with children in my life that don't want the best thing for their kid. We might disagree on how to get there, or again, might not understand some of the factors in their life that are going on. But I think when we kind of put those two concepts together of doing this together in a partnership and honoring and respecting their autonomy to choose as, a sentient human being, that we can make further inroads into that child's oral health than if we did not necessarily start from those places.
That's very good point. So if we just kind of dive into how we have these conversations, is it something that we split this up by like age, by maybe difficulty? I don't know. Like how do we start this conversation?
Yeah, that's a great way to think about it. So many of the questions I get are age specific. So I like that concept of maybe kind of dividing it by age. I think we can talk as well about, some of the more challenging situations that we potentially find ourselves in, because I think there's one of two things that tends to happen, right? Like when we think about this stuff, either we think about an ideal scenario and it just kind of goes, everything goes well and everyone's happy, right? And that's not always the case. Or I think we tend to think about it from the other perspective of the hardest patient that we've ever had, the hardest situation that we've ever had, right? And most of our patients and most of our parents are going to fall somewhere in the middle of those two things. So it is helpful to kind of, I think, talk about some of those extremes and then realize, hey, like the skills that we might use for either one of those things are going to be helpful and probably more effective, than they are in either one of those two extremes to begin with. But I would say, what I tend to hear from people, the questions that I tend to get when I'm working with professionals are, what age does it make sense to like start talking with the patient themselves? So it's like, at a certain level, when you have a 1.5-year-old in your clinic, you're going to have to talk to the parent because the patient can't talk, right? I have a 2.5-year-old son and a 5-year-old son and a 7-year-old son, and I'm probably going to employ slightly different strategies with each of those, but they each can have a relatively reasonable conversation. And so I would kind of categorize that a little bit differently. And then I think you get to the stage of teenagerness, right, where we have a lot of conversations about teenagers and how disengaged they tend to be and how difficult they tend to be as a group. So those are kind of the categories that I tend to hear. So if it makes sense for you, happy to kind of talk about specific scenarios in each of those or questions that you might have, or you let me know.
Well, no, that sounds really good. And then I wonder if that becomes even more nuanced in those categories when we look at prevention conversations versus disease or treatment conversations. Is that the case?
Yeah, I think so. I think that there are certainly, strings that run throughout each of those, right? Where ultimately you're going to have a conversation with the parent no matter what, right? Because until that child is an adult and can make their own decisions or they're fully emancipated or whatever, you're going to have a conversation with the parent. But each of those requires, different pieces of, hey, obviously in the younger kids, you're going to be really having that conversation with the parent. As you get to have, some of those older kids, I do think it's really important from a teaching children how to manage their own health, right? That you involve them in those conversations from the perspective of like, hey, what do you prefer? What are you thinking? Even if the parent decides something else, right? And I tell that to my kids all the time. Like, I want to hear your perspective on this. I might not do what you want to do, but I want to hear your perspective. Your opinion is important to me. And I think that teaches kids about the importance of, hey, you have a voice in your healthcare as you get older. It's not just listen to whatever the dentist or hygienist or doctor or whoever tells you, right? Like, we want to teach these kids that you do have a voice. And so, I think that, there's that spectrum of like moving from that very young child who you're obviously not going to have that conversation with them at all to like, how do you train these teenagers to become informed healthcare participants, right?
Yeah. And motivated and moving them into that like less ambivalent stage and into, what is it? More of a readiness.
Yeah, totally.
Yeah.
I think, moving them along that spectrum, I think is really important. So we can definitely dive into a lot of the nuances of that. You guide us, you help us go where you want to go. I'm interested. So let's talk.
Let's start with like the younger population. Are like, would you even say like 5 and under?
So here's like my general rule of thumb on this is that I tend to think about, if I can have a conversation with the child, I always want to try. Right. Okay. So if the kid can talk, I want to engage them. I want to like be present with them. I think that helps build trust and rapport with the parent as well. Right. Because they see me trying to interact with their child. They see me trying to, get them to smile, listen to them, hear from them, sing them a song, whatever it might be. Right. They know that I'm interested in their child versus, it's pretty easy at that phase to just be like, well, open your mouth and like, let's look at your teeth and let's talk to the parent. And the kid is just kind of a bystander to this whole process. Right. So my kind of general guideline is, if you can have a conversation with the child, have that conversation with the child. It does something for your relationship with the parent as well as with the child, obviously, that I think is really important. So I don't put a hard and fast like age guideline on that, but that's kind of how I tend to think about it. But from there, obviously, I think 5 and under, 6 and under, some level of can I really, like, if I'm having a conversation with them, is it pretty ridiculous? Is it, can I trust what they're saying? Like, are they good historians at that point, right? And so to some level, but I want to get them interested in oral health as early as I possibly can, So I'll be like, tell me about, brushing your teeth to a 4-year-old. And they might not know. They might be like, yeah, I brush my teeth with an alligator. Cool, whatever. Like, I don't care about what they're saying at that point, right? Because I'm not trusting them necessarily to be an accurate historian. But I am trying to engage them there. So
that's good. Okay.
Yeah.
So let's say in that situation, you're having that conversation with the child, and then how do you engage the parent in those discussions?
Yeah, what I usually tend to do in those, and actually I think this kind of tends to run throughout, and this is, again, just my approach. I don't think that there's a right or a wrong approach here. You're certainly going to get pediatric dentists, and I'm not one of those, but you're certainly going to get pediatric dentists who are going to say a specific thing to you, and, great, and other pediatric dentists will say something else. But what I tend to do is I tend to talk to the parent first and say, hey, after I've introduced myself, told them a little bit about the agenda, asked them what questions they had, what's important for them to discuss today, why, what matters to them, right? After I've kind of done that work, then I'll say, look, I'm going to talk with your kid for a little bit here. We'll do everything. And then I'll come kind of back to you and talk to them unless I have any questions. So I kind of divide it up almost, where I can then say, all right, I am going to try to pay my full attention to the child, like while I'm doing an exam or while we're doing something. Because at that point, for the most part, parents tend to interject with things that might not be helpful or, whatever. And it's like, we can do this later. It's not,
right.
What's important here is the engagement. What's important here is the actual interaction with the child versus telling you something about what you've seen or whatever, right? So I tend to kind of view it in those parts of, hey, I'm going to talk to the parent about what's going to happen and what they want to happen, and do all of that work on the front end, interact with the child, and then kind of move back to the parent, if that makes sense.
Yeah.
And I tend to do that actually with all ages. So, obviously the interaction with the child looks different at each of those stages, but I tend to try to say, hey, look, I want to interact with your child, unless we're talking about a very young child who can't talk at all.
And is there any conversation or discussion that you have about their oral health or their condition, overall health, behavior that's not in front of the child?
That's a really good question. I mean, I think as, kids get older, there are certain things that tend to become, very sensitive potentially. So if you're working with a teenager who has an eating disorder or, is using drugs or something like that, right? Like that obviously becomes a much different conversation. And those are never easy conversations to be had, right? And so I think what I see in those situations, it tends not to be about oral health, although it might have oral health manifestations like an eating disorder. But generally, you're going to need to get a team involved in that situation, right? If it's the first time that someone's hearing about it, a lot of parents will come in and be like, yeah, my child has an eating disorder. And we know that, right? We were seeing a therapist and we're doing all the things necessary to work on that. Great, right? Like it's no longer a secret. But if you feel like, wow, no one has talked about this and we're seeing signs of bulimia, in this teenager, that becomes more challenging. And I would say becomes more of a conversation for a team to have versus like, hey, and I would say in that situation, again, I don't think that there's a perfect answer here, right? Like it's a really hard conversation, but I would always tend to approach it with the patient first. Again, I mean, especially as you're looking to kind of create informed people who are making decisions about their health. Obviously, this person at that point is sentient enough to like have an eating disorder and understand like, not that they're choosing the eating disorder, but they're like making decisions based on like why they're doing what they're doing, that they can talk to you about that,
Right.
if they really want to. So I don't think like going straight to the parent in that situation or whatever is ever necessarily all that helpful. You might choose to have that conversation with the parent as well. But I think those have to be played individually.
I feel like that makes sense, and it kind of does apply to a lot of, teenagers smoking. I would even say like excessive snacking and choosing. At that point, maybe the parent should take hold of the diet. But like if they are 12, 13, 14, like they're making the choice to pick up that food or not brush their teeth or chew on something that they shouldn't be chewing on, or I don't know, like so many situations. I'm trying to think of my nephews that are like 6, 11 and 13. I'm like, they're each one are doing something ridiculous.
Totally. But I do have, I mean, like there's a very specific patient that I have in my brain who was probably about 16 that I saw a number of years ago. And the way that I address smoking in all patients is essentially looking at their health history, because we're asking about that. And, you know, like at what level are you interested in quitting? And I always just ask the question, tell me more about like why you chose what you chose, right? Like so some people are like, I'm really interested in quitting. And other people are like, I'm not interested in quitting at all. And some people are like, I'm kind of in the middle. Tell me about, you know, why you're interested in what you chose, right? Which I think is a very curious question, allows them to kind of say, well, yeah, this is what the part smoking has in my life. Obviously, that's different for a 16-year-old. And so especially when they say they're very interested or somewhat interested in quitting smoking, you know, I'm like, tell me more about that. Like, why are you somewhat interested? Like, why do you have any interest in quitting smoking? And the 16-year-old is like, yeah, I just watched my friend's mom die of lung cancer. And that was really terrible. And, you know, I know that this can cause that, but like, you know, here I am 16, like started doing it and I like it kind of, you know, or whatever. And we ended up having this really, I think, honest and meaningful conversation that I think I could have, you know, gone to his parents and been like, he really shouldn't be smoking. Right. And it's like, well, everyone knows that. His parents probably know that. He probably knows that.
Right.
Instead, like here he is finding the reasons that he wants to quit smoking and talking about them. And, you know, then I'm able to kind of go to other care team members that we're working with for him to say, hey, look, like, you know, here's what he's talking to me about. And I'm happy to follow up on that next time, but you guys are probably seeing him more. So, you know, maybe you can talk to him about that. Right. So to me, that was always something where, again, I think it just shows the value of going directly to that person, because you're like, well, yeah, 16-year-old, like you have a reason for doing what you're doing. Let's get into that and figure out why you might be interested in making a change.
Do you feel like when, let's say we have a patient in our chair, maybe 7, 8 years old, you know, like the oral hygiene is less than ideal. Maybe the parent still needs to engage in the nighttime routine. Do you still have that conversation with the parent in front of the patient?
I mean, I think that's dependent on the parent too, right? Some parents want to be there the whole time and whatever. And some parents are like, yeah, just, you know, call me in at the end or whatever, right? So I think that's patient specific. But yeah, I would say I'm always, even if the parent's there, like I'm always kind of talking with the child, right? About like, hey, tell me what you're seeing. Tell me what you're doing. Like, oh, is it okay if I share some of what I see with you, right? And then usually what I'll do is kind of like, hey, I'm going to like talk with your mom or your dad at the end of that, right? So it's like they're kind of the fly on the wall in that situation of, hey, I'm still talking to the child. You're hearing what I'm saying, obviously, because you're in the room if you are. And then we can kind of move to, hey, parent, here's what I'm seeing. Here's what that means. You know, here's what our options are. What do you think? How do you feel? And so I just see very few situations where it's not worth it to like at least try to talk with the kid.
Okay.
You know, from the perspective of ultimately, like if I can get that 7-year-old or that 5-year-old, I mean, I have a 4-year-old, right? Like he has very specific desires on whether he or not he wants to brush his teeth. And, you know, me just being like, I'm going to brush your teeth, whether you like it or not, certainly that is possible, right? But if I can engage him enough to like, hey, you know, here's what we can do to make this a little bit more fun for either of us. If he wants to, even then if I have to do it, he's much more helpful. He's much more, you know, enjoyable in that situation, all of those things, right? So I would say it just as I think just a good rule of like, hey, you know, like people tend to be pretty thoughtful from a pretty early age, as long as we like give them the credit for that. And let's try. And if we can get them a little bit more excited about brushing their teeth or snacking less or doing whatever it might be, it's only going to make the parent's job easier as that conversation goes, right? I don't want to drive a wedge between like the child and the parent either, of like, your mom is going to have to brush your teeth. You know, before we started recording, you talk about, you know, a situation where maybe a parent weaponizes, you know, the dentist against the child. But we don't want to drive a wedge between them either of like, hey, here's something you hate and your mom's going to have to do that every night, or your dad is going to have to do that every night for you. Have fun, right? Like no one wants that.
Right. Well, because what I'm hearing is like, I mean, even a 4-year-old wants some level of autonomy, some level of independence, some level of like, I want to make a decision because I'm old enough, even though they might not be old enough. They still want some ability to I have a say in the situation or how this situation goes down, right?
Yep.
So I think that's great.
This is absolutely 100% not a book about how to have conversations with patients. It's a book for parents on how to have conversations with their kids, but I think it has a lot of applicability. It's a book called How to Talk So Your Kids Will Listen and Listen So Your Kids Will Talk. Came out in the late 70s. A couple authors who would go around and go to all these parenting things and be like, hey, this is what we've learned and here's how to do that stuff. And now it's had, 1 billion editions and it's really successful. And some of the same, skills that we're using in motivational interviewing, other person-centered communication styles and strategies are very much coming out in there. And it's true. Yeah. People want some sort of autonomy support no matter their age. I mean, I have a 2.5-year-old and he's very, very stubborn. And it's like, the more I can do to engage him where he's like, yeah, I want to do that, man, the more easy it is for everyone in our family. And so the more we can do that as oral healthcare professionals, the easier we're ultimately making it for the parents and the better we're making it for the patients, I think.
That sounds great. I would love to, I guess, get your thoughts around the conversation where the parent is the difficult one in the room, the one that's, and not to say that all parents are difficult, because I mean, how great it would be to have somebody that is in your chair, or the patient's in the chair, the parent's like, yes, I hear you. I want to be a better brusher for them. I want to, I didn't know juice caused cavities. What can I do? What a dream. Yeah. We wouldn't see the rate of decay and disease that we see in children if that was most of our situation. So I would love just to kind of talk about the conversations around when a parent's like, well, all they'll have is juice.
Mm-hmm.
How do we get them to move to that space where they're like, okay, I hear what you're saying. I mean, is that similar to the conversations that we would have with if they were the patient in our chair?
Yeah, I would say so. I mean, and I think that, so I've done some work with the UCLA pediatric dentistry residency over the past number of years. And one of my favorite exercises that we get to do is, all the residents videotape themselves working with a patient or, audio record. And so then we coach them hey, here's what happened during this interaction. Here's how this is going, whatever. It's really beautiful. All the feedback from the residents is always, it's the most impactful thing for me. And so let's talk about the difficult piece of hey, when the parent is difficult. And that's certainly a question that, a lot of them tend to ask of, hey, I have this, helicopter parent who tends to, always be doing this and it's really hard. And that, or their kid runs the household, whatever. Those are obviously questions we get. But when I watch some of these, these recordings or listen to some of these recordings, and I have a parent who's saying literally, this is in one of my trainings. And so it's this is probably close to verbatim, but a mom of a between 1 and 2-year-old says to the resident, I can do it, meaning I can brush her teeth twice a day. But I just want to find a fun way for her to, make it fun for her. She tends to, not be super happy about it. And I just want to try to find a way to make it fun. And so it's this mom who's really searching for hey, I can do this and I'm capable and I will do it no matter what. But I want to make it fun for her. And instead of recognizing that desire in the parent, right, the resident in the moment, essentially says to the parent, well, you're just going to kind of have to do it and kids cry. And that's just sorry. Right. Doesn't lean into that. And so I think there's so many more of those situations that are out there that we, that people just miss, right? Where they're missing that desire, that intention, either because we haven't asked about it or because we simply just miss it. Right. I don't think that he elicited that from the mom. It was just something she gave him. So it felt like a softball, just tossing it across the plate, slow pitch softball. And he just kind of took a big swing and missed. That to say,
didn't even swing. Didn't even swing.
Yeah, exactly. Just was come on. But obviously we have those situations with parents where they, where they do whatever the kid wants, right? They scream and cry if, they don't get juice, or they scream and cry if they don't get whatever they want, right? And those are really hard situations again. And I think the way that I tend to approach those conversations is, again, assuming best intent on behalf of the parent. Hey, you want good things for your child. And a lot of times in that situation, I'll tend to share information in a way that hopefully helps them understand, what I'm truly trying to say. And so in motivational interviewing, that is elicit, provide, elicit, or explore, offer, explore, ask, tell, ask. Different ways of thinking about the same concept. But hey, tell me what you know about, how juice can impact their teeth or, whatever. And if they're like, yeah, I know it's terrible for them, right? Well, cool. Now I don't have to tell you it's terrible for them, but I can kind of then either ask some follow-up questions or so what are some things you've tried to do to like change that? Or like, what are some things that have happened, right? I just tend to try to be curious in those situations instead of trying to be directive where, I think that in those situations, it's like, that's not all that helpful. Like we have to develop solutions together at that point that are going to work for the parent. And so it might not be around juice at all. It might be like, you know what, honestly, keep giving them juice because we can't come up with something that you think is going to work. But there's so much else we can do to then work on your child's oral health that maybe they're willing to do. So let's try some of those things, right? I think a lot of times as oral health professionals, we get really dialed on like one thing that we see that's a huge problem or huge leverage opportunity, if you will. And that's good, right? Because we want to identify high leverage changes that patients can make and help them, actually make those changes. But if that's not possible, or if that's too difficult, well, then let's make some small changes that are wins and let's like build up to that, right? Like we don't have to make all the changes in one moment. And, that's hard for us. That's really hard to like wrap our brains around. I think other professions tend to do it a little bit more help, or at least have concepts. So like in addiction therapy, there's a concept called harms reduction, meaning that, it's better to drink 12 beers than it is to drink 30 beers. Like no one is saying that drinking 12 beers a night is a good thing, but we're certainly recognizing that like, hey, if you were drinking 30 beers and now you're drinking 12, and I think we could apply that to say like, hey, it would be great if you could do all of these oral health behaviors, but like, if we can't work on the juice thing right now, if we can't work on this thing that you just feel like is so firmly entwined in your life that you just can't think about changing it as a parent, right? What else could we work on? And that's certainly going to be better than all the bad things that, potentially were happening before. So I don't know if that lands or resonates with you or with, with the listeners at all, but I think for me, it's a helpful concept.
No, and it's very similar to what we talked about in the past, interview that we did, was having those open-ended questions coming from a place that's more curious and not so much shaming. Like, well, why would you give your kid juice? Don't you know that's why it causes cavities? Or like, why aren't you brushing their teeth? Like, you think they're old enough to do this? Like, maybe that's sometimes what's going on in my head. I am working on correcting the narrative and before it comes out of my mouth into the patient, because it hasn't gotten us anywhere in dentistry, right? We're also very frustrated because we feel like we're having these same conversations over and over again when really the change behavior needs to be in our delivery and in addition to what they're doing at home.
Totally. And I think what you just described is like a perfect example of what I like to call, like what I tend to say is like sitting on my hands, right? That there's just moments where like someone's going to say something where we're like, oh no, that's a terrible idea, right? And it's like, you kind of have to sit on your hands because we know that saying, oh no, that's a terrible idea, you got to stop that,
right,
is going to be probably the least helpful thing you can do in that moment, right? There are certainly ways we can communicate that effectively. And hopefully we just talked about one of those via sharing information. But yeah, I mean, and I think sometimes we think we have it hard, right? Like a lot of the training that I did originally in motivational interviewing like years ago was with, pregnant women who were drug addicted, who had HIV, and, were homeless. And you're like, wow, like that person who's working with that patient, they've got a lot more going on than like your kid is drinking too much juice, right? Not that it's not important, right? But I think that like sometimes we tend to be like, if you don't change this, the world is going to collapse. And then we tend to put a lot of pressure on ourselves instead of being like, hey, look, like obviously this isn't helpful for your kid's oral health and it can cause some serious problems down the road. Like, let's discuss that and let's have a conversation about that instead of like, you have to change tomorrow. Otherwise, like, can't you see you're harming your child? And you're like, okay, that's going to, and not that people are saying that, but I think sometimes we feel that. And then that comes across to the patient in a way that's not necessarily helping build trust and helping build loyalty and all of those things with them.
What would be, and depending on what side of the fence you land on with fluoride and other things, when you see a patient that is in need of remineralization because of the amount of like early lesions or straight up tooth decay that's happening, but the parent does not believe in that, I know that there's a lot of other suggestions that we can make for them, but like, what would that conversation look like if you could give us an example? Because I know that's what a lot of people are struggling with.
Yeah, totally. 100%. And certainly I get that question a lot in terms of like, hey, we tend to think of fluoride as the panacea, right? Of here's the savior for all dental problems. And it's great. It really is great. Like it can do so many really good things. And so the way that I tend to approach that conversation is, so, in that situation, we're talking about a kid who has white spot lesions, right? So, I would talk to the parent and be like, hey, this, child has some early cavities. Here's what we're seeing. Here's where they are, blah, blah, blah. The first thing that I would always say in terms of treatment. So if we're talking to a parent about treatment, and if we're talking to a patient about treatment, but we're obviously talking about parents today, it's really important, I think, to offer them options. So not just here's the answer, here's the one thing you can do, here's, whatever. Like there are options, and there always are, right? Even if just the other option is do nothing, which is always an option. But there are,
but it's an option.
It's an option. And oftentimes, like just even presenting that is like, hey, there are options. One of them is to do this. The other one is to do nothing, right? Like all that does for the parent is then help them choose the actual option and feel like they're choosing it instead of like it's being forced upon them, right? So, it's like this psychology that we miss out on of like, hey, when we're presented with options, we tend to want to choose the thing that's best for us generally, and so not a lot of people that I know are choosing no treatment, right? When treatment can help.
Right.
But it does tend to make people feel more in control of their own oral health, which we certainly want. So I would say in that situation, right, like here are the options. And one of them might be fluoride varnish or silver diamine fluoride or, whatever fluoride product you have that you want to talk about. And I think patients tend to fall into one of a couple categories when it comes to that conversation. Number one is there's like some hesitancy, right? I'm unsure. I don't know. I've heard this, blah, 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 that kind of reaction. And that's going to warrant a very different kind of conversation than someone who is very dug in. Fluoride is a poison. Fluoride is, causing my kid to be brain dead, like all of the things that people want to believe about fluoride that are very much of that ilk. And I would say what I tend to advise people is if you have people who are of that second type, the fluoride is a poison type, don't ever put that in my kid's mouth. Like, how dare you even bring that up during our dental appointment? It's not worth it. Just don't go there. Like, it's not like it's like going to Thanksgiving dinner and meeting someone totally across the political spectrum from you and trying to convince them during Thanksgiving dinner that they're wrong.
Right.
Right. Like,
yeah.
That's just is not going to happen. That belief is too deep seated at that point. The only way that change is going to come is through trust, is through relationship, is through time, honestly. And so if that's the first appointment that you're ever having with a patient, like it's just probably not the right time. You're only going to do things that can damage the relationship at that point, not actually strengthen them. And so in that situation, I say, okay, sounds like, you're really against fluoride. Let's talk about all the other things we could do to help your child improve their oral health. For the parent who might just be fluoride hesitant, have questions, not be sure, et cetera, right? That's where I'm really going to kind of dive into, tell me what you've heard. I'd love to share some of the information that I have with you, like what specific concerns do you have? And I think there's some really powerful evidence from vaccine studies that have been out there, which tends to be the closest analog to fluoride in dentistry, right? Until a couple of years ago, that was like limited to pediatricians, right? Now we all have to have the vaccine conversation, and now we all understand what it's like to understand vaccine hesitancy. But in that situation with that person then, or what they found in vaccine studies is that for patients who are hesitant in that way, it is helpful to kind of have a little bit more directive approach from the physician. It's like, hey, this is what we tend to see can be really helpful. We really think it would be good for your child to have a vaccine. If we want to get into like the academics of like the difference between effective care and preference sensitive care, of which fluoride is effective care, right? Like we could talk about that. And again, that might be a whole other conversation. But I think that in a situation where we have something that's so very clearly not dangerous in the way that we're doing it, for somebody who might be hesitant, not like totally resistant, sometimes being a little bit more directive is shown to be helpful in terms of like, hey, this is going to be the best thing for your child. Now, I tend not to, again, use that all the time, but it certainly for those people tends to be helpful.
I think that that's very much the conversation that I would like to have with the parent that was so anti-fluoride. There are other ways. And quite honestly, I think dental professionals need to also realize there are other ways, and also talking about preventing demineralization is a big conversation. Fluoride works in the presence of D-men, but it does. I mean, if there's no D-men and they are doing a wonderful job, pH control is under they're doing a great job at that. Like, why push it when we don't need to? So I think that's a good reminder for us that there are other options out there for people.
Yeah, totally. And I would say, like, going back to the very people who are like very anti-fluoride as well, you know, I tend to always kind of round back and be like, okay, cool. It sounds like this is not an option for you. Would it be okay if we talked about it in the future as well? Right? Because potentially over time, and I have patients like this who have come to trust me more and more and more, right? Where they know I'm not just trying to like push something on them, or know I'm not trying to like harm them or injure them, and they trust me, right? And they become more willing. And it might be, I want no fluoride to like, I would accept silver diamine fluoride because it's, you know, less in the bloodstream than something like fluoride varnish might be, even though fluoride varnish is, you know, incredibly low. But you can look at those, you know, pharmacological studies and look at like, hey, silver diamine fluoride doesn't go into the bloodstream at all. It doesn't cause any spike at all. Thank you, Jeremy Horst, for, you know, reminding us of that, right? And I've had patients that have come to that over time, whereas on that first appointment, they never would have been. But if I had essentially been like, hey, this person is just an anti-fluorider and they're just never going to accept what I say, right? Like, I'll probably just never see them again. And it's probably going to be the same thing for them. And they're just going to continue to have this negative dental experience. So I think I have the opportunity in that moment to be somebody who can prove trustworthy over time, not just to like the facts, but to how they might need to approach those facts, which is with care and gentleness and understanding and, you know, not forcing. And I think we see a lot of that in the world right now in terms of we're realizing, I saw an article the other day. It was like, hey, I developed the vaccine for COVID. Like, the way to do it is not through shaming, but through listening, you know, for people who are hesitant about it. Like, and you're like, yeah, that's 100% true. And we all need to be reminded of that, I think.
Well, and then that technique can be used on so many other areas where a patient or a parent or a caregiver needs to hear their options or have a gentle conversation around treatment. Because, I mean, extractions and huge fillings and putting your child under, those are big, scary things that you might not even understand. Therefore, you say no to it. And having those open-ended questions and being more curious and understanding their hesitancy, I think would be a win-win for everybody. But I also don't think that we give ourselves enough time to have those very curious conversations. And sometimes we get a little in our own world, like, I'm running behind. I haven't gone to the bathroom yet today. Like, and now I got this parent that doesn't see why, you know, their kid with 3 bombed out teeth needs stainless steel crowns. Like, oh my gosh. So yeah, I think that we could all just kind of slow down and take a moment to have those important conversations.
100%. And you're so right on though. I mean, it's something that we have to lean into, right? It's something that we have to commit to because it's easy. It's easy to kind of sidestep those conversations, or it's easy to default to the kind of standard, you know, whatever. And so I think in those situations though, too, what I see from a time perspective is that it saves me time, so much time in the long run to have those meaningful conversations, and just like my own personal satisfaction / like level of burnout with my job, right? No one wants to see a kid who's gone to the hospital come back and have to go to the hospital again. That is a huge failure, right? On so many levels. Like, we haven't addressed the many myriad of factors that cause this to begin with. And we did something that was just very minor and very potentially dangerous. And now all of a sudden they're like back there again, you know, and dangerous in the, like, you know, relative spectrum of dentistry, right? Like, not dangerous is like, hey, this is bungee jumping or something. I guess bungee jumping is probably safe. I don't know. Pick a dangerous activity that actually is really dangerous. But all that to say, you know, I think that for me, when I have those conversations, like, we tend to get to the root cause. We tend to address the things that really matter, right? And that is the stuff that tends to keep kids healthy in the long term, even if they're not healthy in the short term. Even if there are things that we have to do in treatment that the child has to, you know, the parent has to choose in the short term, at least we're not going to end up back there in the long run. Or if we're talking about a teenager, right? Like, at least that child starts to become involved in their health, and you might never see it because they might move away when they go to college and whatever. But like, you might have taught them something very important about like, hey, here's what prevention looks like, and here's how I can avoid this in the future, and here's how my behaviors impact my oral health, and all of that stuff that could save them root canals and crowns and, lots of problems down the road and keep them on the road to oral health, long term. And you'll never see that. You just have to kind of believe that that it's like planting redwood trees, right? Like if you plant a redwood tree in your backyard, you're never going to live to see it grow. But your kids might, somebody's going to live to see that. And you have to believe that work is important, right?
Yeah.
Like that planting that tree is an important part of being a good steward of the earth and doing all the things that we want to do. You just might not live to see it, right? And in the same way, you might not live to, or you might, your patients might just move away and you might not see some of that success that they have long-term because of the time that you took in the short term to be with them.
Right. I do have a question, and maybe there's not a difference, but if there is a child, a separate house or separated household, mom or other parent they're living between two households essentially. And maybe one parent or caregiver wants something different than another. Do you feel that conversation changes, the situation changes? Are you needing to have, let's say, a step parent brings in the child? Like, how do you wrangle the very diverse living environments that we have children in these days?
Totally. That's a really great question. Too bad my wife is not in here right now. She is in family law and so deals with this kind of stuff. She's a mediator for family law. So she deals with this kind of stuff all the time in terms of who has decision-making powers and, all of that stuff, right? So I would say, obviously there's another component to that that's well beyond our professional range, right? Of sometimes parents have joint decision-making ability. Sometimes they have, single decision-making ability, some of that stuff. So, sometimes that might be there. The question that I tend to always ask if I have a parent who is not there with the other parent. So if, and even if it's just one person brings them in, let's say, right. And it's obviously their parent. The question that I tend to ask, and this is very much born from shared decision-making, et cetera, is is there someone else that's not in the room that you need to talk to before you make a decision today?
Okay.
That obviously is more impactful with something like, hey, my kid needs to go under general anesthesia, right? And there's a choice to not do that. You could use silver diamine fluoride, or you could take them under general anesthesia, right? Those are very different choices versus should we put in, a composite or a glass ionomer, right? They look the same as, a lot of times people don't know. So I would say, depending on the severity of the treatment, it manifests itself more importantly that you ask that question, but I think it's a good question to always ask. Is there anyone else here that you need to talk to before you make a decision? And that's a great question as well for older people.
Yeah.
A lot of times you might see somebody who's starting to lose cognitive abilities or something like that, right? But they're still pretty autonomous, and it's their kid wants to have some input or say, right? Or whatever it is. It tends to be a really good question that a lot of times we overlook of you are of an age where you can make a decision as a parent or as, whatever, an adult. But I don't know, maybe you need to talk to your pastor. Maybe you need to talk to your best friend. I don't know who you need to talk to, but ultimately we want you feeling like you're choosing this and that you're feeling really supported. I have a great example from my friend whose mom is a dental hygienist, and she always feels like she comes home and has to justify to her mom, why she made the decisions that she made. And so it's, she's it's actually really helpful for me to feel okay, cool. I know a little bit about this and I had options and here were my options, whatever, because I know I'm going to have to go home and justify this to my mom. So is there someone else in the room that you need to talk to before you make a decision? I don't know. Maybe Allison needs to talk to her mom.
My last question in regards to how we interact with parents. For me, like I said, I don't really treat a lot of children. Mine has always been in the elderly geriatric population. That's the space I love to be in. But during the pandemic or right after, when I went back, I started temping in a general practice where I was somehow these kids, I asked no kids on my schedule, but they ended up there. But they were all very sweet and lovely. But the interaction was drastically different because nobody could come into the office, right? During COVID, I was going to get them from a car and I was doing the treatment and then having to go out to the car and through a cracked window have a conversation with the parent. I can't show them. I mean, now I also think everybody in these situations should thoroughly embrace teledentistry, because I could have then sent the link and done a video call, showed them with the intraoral camera, but in that space, I didn't have that as an option. Like, is it going to be the same conversation, just in a different environment?
Yeah. I mean, and I think we do see that sometimes, right? Where somebody, brings the patient to, the clinic, and it's like, hey, I'm the babysitter or whatever. Right. And it's like, you have to call the parent to like talk to them. There are definitely times when like the parent might not be in the room. Obviously not ideal, right? In that situation in COVID that you're talking about, I can just imagine where you're like, hey, something changed during some treatment or whatever, we got to go out. It's what I like to tell people, especially in a general practice setting, is if something is changing during treatment, sit the person up and have a conversation with them, right? Yeah. Like, no one wants to make a decision about their health while they're like laying down and in a very prone position. It's not a position of power to like make good decisions, right?
Right.
So sit them up and have the conversation. Yeah. So if in that situation where you're talking about, a parent who has to be in the car, a parent who is somewhere else, right? If something happens, ultimately what you're going to have to do is sit the kid up, probably, unless it's like an emergency and you just, it's like a life-threatening situation. You're going to have to sit the kid up, and then you're going to have to go talk to the parent. It's just going to take longer, which is why I think for a lot of people during COVID, they just could see less patients in addition to the aerosol requirements and whatever. There was a lot more steps that were involved. And so is that situation ideal? Of course not. Is it the ethical right thing to do? Of course, so we're going to do that. Hopefully you don't have 5 of those patients in a row,
right?
Because otherwise you're going to be running really far behind, and no one wants that. But yeah. And then, if that's becoming a consistent thing because of something like COVID or whatever, you're probably going to have to look at operational changes to manage that, because at that point, that's what we have to do. So not ideal, necessary.
Well, that seems like a reasonable answer. Operational changes, which we should all be probably rethinking in a lot
there
of
you
ways.
go, right? And no one wants to have the reasonable answer, and everyone wants to have like the magical answer, right? Where it's like, here's how you just solve all these problems without, having to deal with it. You're like, no, unfortunately, that's just not the way that it works usually, right? So we want the magic. We don't want the reasonableness.
Right.
But embracing the reasonableness is going to get us to normalcy as quick as we can in those situations. True. And it's going to get us to good patient care, I think, in those situations, which is all what we all really want.
And as we kind of like wrap this up, are there anything I didn't ask or think about as far as having these conversations with a caregiver or a parent around just pediatric therapy?
Yeah, I mean, I think this isn't necessarily specific to pediatrics, but kind of going back to the like option conversation, I think it's important for us to understand all of those different options. And, I think a specific example that we see from the literature, right, is like, I might have a bias against putting silver diamine fluoride on a kid's front tooth potentially, right? Because I don't want my kid to have a black tooth or something. I would, to be clear, I would be fine with that if that was necessary and that was like easier for them and whatever, helped them have a better dental experience. Like, okay, that's fine. But I think sometimes we think, okay, like I wouldn't want that, or I have specific biases that, this is what I think is the best treatment. And we project those onto other people. But what we see from the literature in that situation is that like most parents, given like the knowledge and understanding of the options, are actually pretty okay with that. And, much higher than we would initially think. I think it's somewhere in the 60-some percentile. I haven't looked at that study in a while, so don't quote me on that. But I know it's relatively high, comparatively speaking. And so I think it's one of those things where we don't want to project our values onto other people when making those treatment decisions. And so helping people understand the risks and the benefits and the alternatives in a way that like takes into account their values and preferences, I think is just so crucial from the perspective of what we talked about at the beginning: partnership and autonomy, respect. And ultimately, when you do those two things really well, you are going to build trust with your patients. Your patients are going to continue to come back to you because they don't feel like you're pushing something on them. They don't feel like you're just telling them what to do, right? They feel like they're involved. And ultimately, that's going to be good for them. That's going to be good for their kids. That's going to be good for, their kids, right? Like that goes down the line of, hey, here's how you can interact with healthcare professionals, like we talked about, which I think is just so important. So from the perspective of teaching parents and kids to be informed decision makers in their own health, that is something that I would definitely say when you're going back to talk about options.
Awesome. That was great. I would love for you to tell everybody where they can find you, learn more from you. What happens on your website? Tell us all of those things.
Yeah, totally. So right now with my job at Different Kinds, you can get in touch with me through that. You can email me directly. My email is matt@differentkind.com. You're welcome to go onto our website and to learn a little bit more about what we do. And like I said, what we do is we help dental professionals measure patient experience and then actually improve that. So, hey, here's what patients really have to say. And then based on that data, how do we actually help you make improvements in that to really build that loyalty, that trust, more than just, is it convenient to come to you? It is, hey, this is the place that I really know and trust, and helping you kind of understand that. So that's all what's happening behind the website. The website just has a contact form and some information about what we do. So the product lives beyond. But yeah, feel free to email me. Check out our website at differentkind.com. Connect on LinkedIn. More than happy to connect there. I don't have any other social media besides LinkedIn, so happy to connect there as well. And I love getting a chance to chat with you, Michelle. I had a chance to chat with the Colorado Dental Hygiene annual meeting this fall, as well as the Oregon Dental Hygiene Association meeting this fall. And it's just so fun to know so many great hygienists in the world, of which you are one.
Thank you.
It's really fun to watch a profession that just dentistry in general, right? Like strongly believe is going in this cool direction, and knowing so many great dental hygienists who are saying, hey, look, like dental hygiene can be so much more than like an instrument in hand. Like, we are oral health promoters. Like, we want to be excellent at that piece, just as dentists are much more than, somebody with a hand piece in their hand,
Right.
So it was fun to be a part of those. It's always fun to get a chance to chat with you, because I see the vision and the direction of true oral health promotion, and really there's just this amazing group of people who have the capacity to really shape the future of oral health in America. So I'm excited.
Well, thank you. It's always great to be seen. I think every hygienist that is trying to make this charge and move the profession to, like, I polish floss fluoride and make a real change in oral health loves to hear that from a dentist. That it means a lot.
It was so funny. So I was at that Oregon Dental Hygiene meeting with Jeremy Horst, and we were, I kind of gave the keynote, he gave the second talk, and it was, all of us in this large room. And man, it was just so fun. We were just like, it felt like we were just the dental hygiene cheerleaders there. We're just like, man, we love you guys. Like, you guys are the best. Like, you're so cool. We're so like amazed at the things that you're doing here in Oregon, especially, but just in general. So it was fun. I will always consider myself the biggest advocate and champion for dental hygiene that I can. So if there's ever anything that I can do to continue to support your mission, please let me know. I'm happy to do that. And that goes for all your listeners as well. I'm here to help support you in whatever way I can.
We appreciate you so much. And thank you for your time. Another great episode with us. And thank you for just the expertise that you shared and doing something different to help us have better patient experiences. So thank you.
Thank you.